So tonight we have the wonderful Dr. Manveen Bedi discussing integrating scleral lenses into your practice. Dr. Bedi pursued her doctorate of optometry in Chicago and her residency in cornea and contact lens in California. Her optometry practice focuses on specialty contact lens fittings for corneal pathologies, management of dry eyes, and myopia control. Dr. Bedi is passionate about teaching, has authored many articles, and presented at several local optometric societies and universities. She is also a fellow of the Scleral Lens Education Society and a fellow of the American Academy of Optometry. No financial disclosures. Throughout the presentation, any questions that you get, go ahead and put them into the chat feature. At the end, we'll do all the questions. So we'll stop the last 10 minutes and get to as many questions as possible, but don't wait till the end. If you have some questions that you want to submit, just go ahead and pop that into the Q&A. Do keep in mind to get CE credit, we do have to stay the full 50 minutes, but we'd love to stay for the Q&A as well. You'll get your CE certificates emailed within 2 weeks, but if you have the OE Tracker app, which you can download now, at the very end, there'll be a QR code that you'll just open the app, scan, and it'll instantly go in. And without further ado, I will turn over the screen to Dr. Bedi. Thank you so much.
Thank you, Dr. Skidmore, for the introduction. I'll just pull up the presentation. Hi, everyone. My name is Manveen, and today we'll be talking about integrating scleral lenses into your practice. So the objective of this lecture will be understanding the design of scleral lens, looking at the indications when to fit these lenses, the advantages of scleral lenses over traditional contact lenses. Then we'll delve a little deeper into setting up your scleral lens practice, which is what are the different diagnostic tools that you require for to optimize your scleral lens fittings, as well as reduce your chair time. We'll talk about implementing strategies for fitting scleral lens fitting protocols, as well as building resources for patient education and guidelines for follow-up care. We'll then go into our staff training, which is again quite a good amount of chunk that we'll spend there in terms of how to train your staff properly in terms of handling lenses, interacting with patients, and troubleshooting scleral lens related concerns. And lastly, we'll briefly touch on marketing strategies to how, in terms of understanding how can we attract scleral lens patients into our practice and how do we collaborate with our referring providers. So as we get started, we'll just talk about the basic anatomy of a scleral lens. So we already know a scleral lens is a large diameter lens. So essentially it's vaulting your cornea and landing on your sclera. So when we have this lens, not only is it masking your surface irregularities and providing good visual outcomes, but the tear reservoir that's built in the scleral lens allows for surface lubrication as well as ocular surface protection. So when we look at opportunities for scleral lenses, the first thing is starting with your own existing patient base and seeing what are different patients that may benefit from these lenses. So for instance, looking at your patient database and seeing, do we have any dry eye patients that may benefit from this constant lubrication and surface protection? Do we have any keratoconus patients or any ptotic patients that may benefit from having more of their visual optimization? And looking at your refractive surgery patients, it's not just your post-LASIK ectasias or post-refractive surgery ectasias, but also patients whose LASIK outcomes or RK outcomes were not quite apt for their vision, and they may want better visual outcomes. So in this case, we're essentially masking the irregularity on the eye surface with the scleral lens. Then there's the next set of category, so where we're looking at patients who may be fitted in a corneal RGP. They may have had an advancement of their ectasia, the lens may have decentration issues, dislodgement issues, and can we improve their comfort and stability with scleral lenses? Then we have our pathologies where we're looking at neurotrophic keratitis as well as lid disorders, where the main goal is ocular surface protection. These are corneas that are more fragile. They have this exposure that can cause keratitis, it can cause abrasions, and severe corneal insults. So having that scleral lens on the ocular surface, that's not only just providing lubrication, but also protecting against the mechanical irritation from the lids can be a beneficial option. And lastly, our refractive errors. We always forget that sometimes we'll see patients who have really high refractive errors that may max out your ability to fit them in a traditional soft lens. So in those cases, if you are looking for optical correction, scleral lenses can play an essential role as well. So when we look at the role of scleral lenses or the advantages of using scleral lenses over your traditional options, we are first looking at comfort. So essentially, we have this large diameter lens getting tucked between your lids, so there's less of that lid interaction, so it's more comfortable from the get-go. There's the aspect of visual rehabilitation. Again, it's a rigid gas permeable lens, so by nature, it masks that irregularity, provides better visual outcomes. We also have that water reservoir or tear reservoir that's built in that's providing dry eye therapeutics for the patient. These lenses are much more rotationally stable on the eye, so there's less dislodgement issues that we're looking at. And lastly, there are technology advancements that we have nowadays where we can do aberrometry over lenses and sharpen up the patient's vision and provide the maximal, optimized like the visual acuity to the maximum. So when we are looking at the picture on our left, we can see that in scleral lenses, there's a whole wide variety of lens options that we can fit essentially. So on the bottom, we have this 3400 micron lens. For instance, if a patient has a cornea plana, like a flatter corneal structure, we can have a smaller lens diameter. Then we go on to our traditional lenses that we fit, which are in the range of 4500s to 5000s for your normal ectasias. And then larger diameter lenses, for instance, if you are working with patients who have severe ocular surface disease, and the goal is to cover as much surface of the eye as possible, or severely ectatic patients, you can go large to kind of cover more of that topographic area on the patient's eye. So when we talk about building, what are the advantages of building your specialty lens clinic? There are quite a lot. First, you're providing better visual outcomes to the patients. There's a lot of different technology advancements that have happened. So you have the ability to do aberrometry, you have the ability to correct the vision to the maximum. So here in this picture, as we see that there is the aberrometry that we did of a patient who had keratoconus or just moderate ectasia. And when we looked at the picture and the values, the higher order aberrations were quite a lot, which reduced the visual outcome. This is the next picture right here is with the lens on when we repeated our topography. You can see that the vision definition is much better. The higher order aberrations have reduced significantly, and the patient sees much better, less glare, less halos, and less shadowing of their vision. The next aspect is enhanced comfort. Again, these lenses are large diameter. They have the ability, there's less lid interaction. There is that water chamber that we built into the lens, so there's constant hydration of the eye surface. And lastly, stability. These are rotationally stable lenses that sit on the eye, less dislodgement and less discomfort for the patients. So when we talk about setting up our practice for scleral lens fitting, there's a lot of different moving parts that kind of go into designing a scleral lens practice. So we'll touch on each of all these different points. So we'll start with equipment and diagnostics. What are the most essential tools that we need? Essentially our building blocks that we need to start with a scleral lens fitting. We'll then go into the scleral lens protocols, which is where we'll establish clear, repeatable process for fitting, follow-ups, and troubleshooting. So it will start from the initial inquiry all the way to the follow-up and finalization of the fit. Next part is staff onboarding. You want to have staff who's adept at fitting procedures. They're adept at testing that needs to be done with scleral lens patients, as well as they're able to manage and coordinate appointments, as well as communication with the labs. Lastly, we'll talk about patient education. We'll talk about designing materials and using videos to educate patients in their journey with the scleral lenses and providing aftercare instructions. So first, we'll start with equipment and diagnostics. So the basic building blocks of your scleral lens practice is the equipment that you're working with. So we'll touch on technology like topographers, different types of OCTs. We'll talk about clinic room supplies. Again, as an optometry practice, majority of us will have a lot of these things already, which will be the fluorescein strips, slit lamp, and then we'll go into more focused approach of like your scleral lens related tools, the DMV suction cups, contact lens disinfection solutions for hard lenses, preservative-free sealing, and photography devices. And lastly, we'll talk about tri-lens sets. So in terms of technology, there's a lot of different technology that's out there, and we'll touch on each of them, and we'll talk about the pros and cons. So first is your placido-based topographers. So this provides you a good snapshot of the eye. We can see our axial tangential maps. We can understand how ectatic the patient's eye is. We can get our measurements for HVID. And depending on the topographer, we can get aberrometry data, higher order aberration data as well. Second thing is cost effectiveness. So traditional topographers will be more cost effective for a practice. And then the multifunctionality aspect. So nowadays, a lot of these topographers have multiple different tasks that they can perform. Some of them have integrated axial measurements, some of them have dry eye suites. So while you're building a clinic, finding another niche that you can repurpose the instrument for helps you with getting better return on your investment. However, there are limitations. First of them will be scleral shape. Again, when we're looking at basic topographers, we are looking at the corneal anatomy, but there's limited data that we get for the scleral shape. So we're looking at extrapolation of data essentially. And lastly, when you have highly irregular eyes, the data does become limited because the eye is highly ectatic and the focusing may become an issue. Second is our shine fluke tomographers. So here we have our more specialized instruments, which are taking almost a 3D reconstruction of the eye. You have the ability to look at the front surface of the cornea, the back surface of the cornea. There's tachymetry data. So there's a lot more data that can help you with disease monitoring. If you're looking to build an interior segment practice heavily focused on keratoconus, this might be a great option in terms of monitoring for the disease in the long term. The cons, however, is the expense that comes with the instrument because these are highly specialized instruments. And the other advantage is that they have these modules that you can also get, which include the corneal scleral profile. So they can extend up to 18 millimeter, where you can get information on sclera and provide customized fit to your patients. The next category is your profilometer, iPrint Pro, which are your highly customized contact lenses, and they can provide you a full scleral assessment. The lenses are highly refined to the patient's eye, so there is a good first lens success that you will see. You will have reduced chair time, and it helps you with fitting those highly irregular scleral anatomies, especially with patients who have blebs or a lot of different types of conjunctival lumps and bumps. However, the concern is, again, cost, both for the practice and for the patient, because they are more expensive than your traditional scleral lenses. Lastly, we are looking at anterior segment OCT. Sometimes nowadays, a lot of optometry practices do have an OCT, so kind of repurposing that instrument towards your scleral lens fitting is always a great option to get visualization of tear reservoir as well as the lens edges. Again, the OCTs don't really provide you the full surface map of the eye, so you have to kind of stitch your images together just to get a full visualization of the lens as a whole on the eye surface. However, it's a great tool for troubleshooting your fits and understanding where you want to make your adjustments. And again, if you do not have an OCT, then there's the added expense for having another device in the practice. So if you were to look at placido-based topographers, so we have this one. This is an image from one of the topographers. You can see that it provides us robust data, not only about the ectasia, it does have information about HVID, higher order aberrations. So that all of that data can be quite useful in terms of designing your lens as well as your scleral lens fitting. Secondly is multifunctionality. As we discussed, like when I first started in practice, for me, it was important to build both my scleral lens, dry eye, and my via control clinic at the same time. So I wanted an instrument that could at least perform two functions. So having a device that not only just helps you with scleral lenses, but also can be used for a different niche practice, so you can go hand in hand, is always a good option. And lastly, the only limitation that we're looking at is the limited scleral mapping. So we are looking essentially at extrapolation of data, which again, it doesn't work a lot of times. So you have to kind of do more manual adjustments on the lenses. Next, we're looking at Scheimpflug tomographers. So here, it's an excellent instrument when we are looking at disease monitoring. We can get information about the front corneal surface, the posterior corneal float, pachymetry, and understand how the cornea is changing over time. We talked about briefly as well, like here, this is your CSP profile. So some of these topographers will have the ability to have corneoscleral mapping, which allows the extension of up to 18 millimeter on the sclera. So with that information, we can design a lens that fits the eye much better. And lastly, reduce chair time. Having a much more customized fitting always helps in reducing the chair time for the patient as well as for you. Then we have our profilometers as well as iPrint Pro. So when we're looking at profilometers, iPrint Pro, it works wonderfully, especially with your patients who have very complex pathology and complex eye shape. For instance, the picture that we have on our left, we can see that this is a highly prolate graft that was in a patient's eye. When we are fitting it with a generic scleral lens, there will be areas that are overvaulted and then areas that are undervaulted. And the main concern that becomes is the oxygen permeability that's going to the tissue underneath. So the health of the tissue can get compromised. In such cases, it's a perfect opportunity for us to extend into iPrint prosthetics and profilometry to get a much more optimized fit for these patients. Second, it is a customized fitting. It's almost like as fine-tuned as taking a fingerprint off your eye and then designing a lens based off of that. So it provides the best outcomes for your first lens and optimizes the fit as well as reduces your chair time. So when we look at anterior segment OCT, I've had quite a good amount of experience with the anterior segment OCT, and it's been quite helpful when we are looking, especially at the landing zone. Again, there is time that is spent in terms of stitching the images and getting an overall assessment of the eye as well as the lens edges, but it does help visualize how the lens fits on the patient's eye. And in terms of adjustments, if you look at the picture on the right, we can see that over here, there's conjunctival prolapse and the lens is overvaulted on the limbus area. So having that image that helps you and can kind of guide your fit in reducing that vault and reducing that prolapse can be quite helpful in the clinical setting. Now comes the next portion, which is fitting set. So when we're looking at fitting sets, I always prefer to have, like when I first started, I always started with 2 fitting sets that would provide me the ability to have multiple different features across 2 different fitting sets so I could do more comprehensive fits. And it can kind of change the lens brand depending on how the eye looked topographically. Having the ability to fit smaller eyes as well as larger eyes is always helpful to the diameter of the lenses, and having a brand that helps you provide you like a wide range of diameters is quite helpful, especially when you're fitting an eye that might be a microcornea or a cornea plana eye versus a dry eye or a highly ptotic or macrocornea. When we are looking at the bottom in these 2 pictures, we can see over here, there was a conjunctival cyst that was present. So we kind of went over to do a vault with the lens. And in the next picture, we see a notch. So again, having labs that have the functionality to do notches, vaults, recesses, it's always helpful. Lastly, looking at lenses and the features that the labs have, whether we can make quadrant-specific changes or if you can make meridian-specific changes, bi-elevation changes, those are really helpful when you're optimizing the fit for the patient. So as I said before, the first thing is looking at features and modifications that are available in the brands. Secondly, looking at brands, and some of the brands have these little advances. They have some advantages over the other. For instance, if you're looking at OneFitMed, they have these grooves on the surface of the lens. So when you swap fluorescein on the lens, the grooves kind of get highlighted. So it's easier to determine which area of the lens is the problematic area and that you would want to focus on and help modify that specific part. And lastly, looking at consultation support. Majority of the labs have excellent consultation services. So working with your consultants to help you design the first few fits up until you're comfortable is always a good option. In terms of photography, when I first started with residency, my goal was to have to capture as many fits that I did, just to make sure that I can track my fits and modifications and see how the modifications were happening in real life versus just calling consultants and then getting the answers. So when you are photographing your fit, you kind of get a sense of what areas are becoming problem areas or how your population in general is responding to the lens. And sometimes there are trends that kind of develop from there. So for instance, at the top three pictures that I have is just with my phone next to the slit lamp without even having any adapters. So you don't always need the best of the technology in order to capture good images. Sometimes just putting your phone next to the slit lamp will get you good images. So in this one, we can see there is that seepage of fluorescein across the toric markers. So we know the lens has an edge lift, so we can get it tucked in to reduce that midday fogging. And over here in the slit lamp, in the optical section, you can kind of appreciate a little bit of fogging that's happening in the tear chamber and then the surface fogging on the lens. So you can do quite a lot with just a phone next to your slit lamp. The bottom picture that I have here is with a topographer. So like the topographer had the ability to capture pictures. So now we just have the staff kind of run pictures on the eye with the lens just to get a sense of how the lens fits. And we can see the microvasculature in quite detail. Other options are having adapters. There are different companies that have different types of adapters that are present, as well as having slit lamp cameras if you have access to those. So when we are starting, it's key to start with just the bare essentials, and at least that's how I kind of started. So starting with 2 different lens companies that can provide you a range of customization, so you have the ability to make modifications as you go. Then we are looking at the basic setup in the clinical room and having a photography device, whether it just be your phone that you're putting against the slit lamp, just to monitor your initial fits as you get more comfortable during the fitting process. And lastly, looking at technology, looking at the device that actually helps you justify or has the best return on investment, or can be used against multiple different clinics and provide you the best patient outcomes. So the goal is just master the basics and let your success kind of fund the upgrades that you do in technology. So the next part that we'll talk about is our Scleral lens protocol. So in terms of protocols, just building detailed guidelines for the staff and for just the team in general, from the point of inquiry all the way till fit finalization and ongoing care is important, just to have a repeatable process that provides and optimizes the patient experience. So in terms of inquiry, so when the staff gets the first phone call about a patient interested in scleral lenses, training them well in terms of responding to their inquiry or referral and providing brief overview of the process, time commitment is important in setting realistic expectations from the get-go. Then we go into patient history and how do we kind of coordinate care between different providers for the patient. We'll talk about the consultation process and how you can use your team in terms of pre-testing, consent form procedures, and patient preparation to maximize your outcomes from the visits. And lastly, we'll talk about your fit completion and the follow-up. So how do we schedule your appointments? How do we maintain the answer concerns about contact lens care, replacement schedule, and products, especially that are required for specialty lenses. And lastly, we'll touch on the ongoing care, which is just future monitoring for their eye pathology as well as for contact lenses. So in the inquiry stage, our standard operating protocols will have specific questions that are detailed for the staff to ask when they receive inquiry for scleral lenses. It may just be as simple as asking, like if the patient has some sort of visual correction that works, or they have right now they don't have any visual correction. What condition have they been diagnosed with for which they require scleral lenses? Have they had any surgery, whether it be cross-linking, LASIK, or graft? Then we try to then coordinate their appointments or coordinate care from their local optometrist, or if it is a patient inquiry by themselves, then we'll ask them for their most recent eye examination to ensure that the eye examination retinal checks have been performed before we take on the care. If there is any topographies, notes, especially surgical notes, we'll always request that prior to the consultation so we can maximize information at the consultation and make our decision moving forward. Next step is setting clear expectations. So normally the staff is trained to tell the patient that Specialty contact lenses are a much more involved process. It takes more than a visit to finalize the lens. There is a lot more time commitment that is involved. So the patients understand that the appointment may not be just a routine 15 to 30 minute. It may last as long as an hour in the clinic. Then we're looking at encouraging to schedule a consultation. So that will be the next step to just say like, hey, when we get all your results, we'll schedule this consultation and then we'll assess your candidacy for the lenses at that appointment. And in the email, when they're sending out the consultation appointment, they'll also send out our digitized Scleral lens brochure for the patient. So for them to review what lenses are, how they work, what the candidates look like, and how does the lens work on the eye. At the next stage, which is pre-fit evaluation, so this is when the patient comes in for a consultation and we are discussing their medical history. The main thing that we are trying to rule out at that point is we are trying to understand what the best corrected visual outcomes will be for this patient and ruling out if they have any retinal macular pathology that may compromise their visual outcomes. Second thing, we're looking at corneal stability. So normally I'll have a discussion with the patients if they've had cross-linking or not, and what part of their eye care journey are they in, and how I can help them in the process. So for instance, if a patient comes in and tells me, hey, I have had these changes in my vision over the past year, and my vision has degraded. I haven't done cross-linking, but I am on the fence to do the procedure. My first discussion point is, let's figure out if you will be going through cross-linking. Once, again, I always prefer everyone to have cross-linking first before we start with the fitting, just because it's a more stable structure and less chances of eye progressing, scarring, and pathology. So once we've confirmed that the patient will want to proceed with cross-linking, I'll delay the fit to after cross-linking and after the eye has stabilized. However, in cases where the patients have very poor functioning based on their vision and they would want to get started with their Scleral lens fitting right away, we do have an open and honest discussion about if you were to do the fit right now, there is a chance that the lens will change, the prescription may change, and a refit may be required. So once you're having those discussions, it sets clear expectations, everyone's on the same page, and there's more transparency built around the process. The other thing I prefer to do at the consultation is getting a baseline assessment of the ocular surface health assessment. Whether it be a simple dry eye questionnaire, I prefer the DEC 5. It's a simple five questions that I can ask the patient, get an assessment of how uncomfortable the eyes are. Again, these are highly ptotic eyes, so the tear film stability is poor on the surface. And a lot of times patients will have lens surface fogging, midday fogging, and some of them may be related with their dry eyes. So getting that baseline assessment is good. So before you start the fit or while you're waiting for your lenses to arrive, you can start them on a dry eye therapeutics. So that way the eye health is optimized before the lens goes on. The second thing is the last part is getting a baseline data. So we're looking at topography, we're looking at getting refraction, best corrected visual acuity with glasses. We're looking at HVID, pupil size, and then we go into putting the lens on the patient's eye. So when we are looking at trial lens selection, the best way to start is looking at the fitting guide of your lens brand that you're using. So normally they'll have your K values, they'll have your HVID, and based off of that, they'll tell you which lens to start as the initial lens. And I would say put the lens on and then get started with the fit. Normally, when we have the lens on, we won't just go straight to checking vision or the fit right away. We'll just take a blue pen light and then shine it on the patient's eye just to get a sense of the fluorescein pattern on the patient's eye. If there's touch, we'll just increase the volt up until there is that green fluorescein pattern across. So that way we know that there's no touch, and then we'll start evaluation of the lens. The other trick is looking at the patient's temporal profile. So as we can look in the top set of pictures, a normal eye looks quite spherical when you're looking temporally across the patient's eye. In keratoconic eye, depending on where the apex lies, you may see more of a steepening as well as a decentered apex of the eye. In keratoglobus, you will see this global steepening of the eye in a highly ptotic eye. Lastly, when you have cornea plana, it is a flatter eye. So you already know we are going to start with a lower sagittal depth of the contact lens as well as a smaller diameter lens. Lastly, when we have the lens on the patient's eye, we've established there's no touch. I'll have the patient kind of wait for 30 to 40 minutes before I assess the lens. Now, when the patient is waiting in the waiting room, like 10 minutes before I need to bring the patient in my room, my staff will go in and they'll get started on the testing. So with the lens on, they'll do their autorefraction over the contact lens and they'll do topography over the lens. So the goal of the FIT evaluation for me is to maximize data collection on the first day that we have the trial lens on the patient's eye. When I'm building that wait time of 30 to 40 minutes, it's helping the lens settle on the eye. I can get better data about tear assessment on the patient's eye. There'd be better data on lens settling and how the conjunctiva is taking to the lens, and also just have the patient adapt to the lens while they're in the waiting room. So in this case, as you see, like when we take photos of the lens with and without the contact lens, when we're doing topography over the eye, you can clearly see that right after we put the lens on and we do a topography, the cornea is much more like spherical, less flexure, eyes looking good. We already know that overfraction would be minimal. We do not have any residual flexure that's happening on the lens surface. And with the aberrations, the higher order aberration data, you can see how much aberration control you have by just a generic scleral lens. And then once the data is there, we'll start with our refraction over the lens and just see what the parameters we need to modify for the contact lens. In terms of follow-up, like the follow-up is focused especially in terms of application removal training and setting realistic expectations for lens adaptation. This is more important for your patients who you're fitting monocularly. A lot of times you'll see patients who have one good eye, a form frost eye or very mild keratoconus, and the vision is quite good even without any optical correction. And it's the more advanced eye that they want you to fit. However, when you fit the more advanced eye, majority of the times what I've noticed is that their vision becomes much better in their eye, the advanced eye with the lens on, than their good eye. So the ocular dominance shifts and that takes adaptation. So I prefer that no one in the clinic tells the patient that you'll love the lens right away, but we tell them like it will take a week or two for you to adapt to the lens. So give it time and let the lens settle and your ocular dominance might shift. So it prepares the patient to understand that there may be more adaptation that they're looking at. If the lens looks good in the first visit and they're just minor tweaks that I'm looking at, then instead of making the tweaks right away, I will bring the patient back in a week and I'll have them wear the lens 4 or 5 hours prior to the appointment. So that way, even before we make adjustments, we have confirmed our overrefraction. We can check how the surface is responding to their tear film if we need to add any coatings. And we can also look at how the lens settles on the eye. So it provides you the best amount of information prior to you jumping to make a change. When you are bringing the patient in that 1 week follow-up, I always like to remove the lens myself because it gives you a good idea of how the lens sits on the eye. If there is that pop sound, you know the lens is a little bit tight, you may want to lighten up on the landing zone. If you're putting fluorescein in the eye and checking the eye afterwards, you can also look at if there's any limbal staining, any corneal staining, any areas of touch after the lens has settled, or ocular toxicity. If they're not responding to the solution that you've recommended for them, you may want to change the solution. So it's always important to remove the lens yourself at the first visit, as well as assess the cornea and just see how the eye's adapting to the lens underneath. In terms of efficiency, it's all about optimizing your workflow as well as the patient experience. So building out your templates from the get-go for your evaluation. And some of the key components that I look at is your toric markers and the dots. A lot of these lenses will have dots on the lens surface that will tell you how rotationally stable the lens is, and toric markers as well. So exactly knowing where the toric markers are, especially when you're adding any sort of over refraction, is helpful. If you are making changes to the landing zone, it's helpful to know how the toric markers are aligned and how the lens sits on the patient's eye. And then having specific notes about your limbal zone, landing zone, central clearance. Is there any fogging underneath the lens? Is there fogging on the lens surface? So you can capture that data and then make changes as warranted. Second is building your scleral lens team. So you do want a person who's in charge of streamlining the process and the appointment scheduling. They should be trained in diagnostics, lens care, application removal, as well as coordination of the patient appointments and communication with the lab. Lastly, we're looking at building handouts as well as getting videos that patients can use at home and that can increase compliance to the way they should be using the lenses. So normally in our clinic, we have automated, like we've made these email templates and brochures that we'll send out to patients so that they can prime themselves with how the lens works, how the lens should be applied, removed, and the list of do's and don'ts for them to get familiarized with them with the lenses even prior to their application removal training. So this is more of a summary slide, which talks about the clinic flow, how to kind of address your pre-fit triage as well as intake, what is happening on your clinical fitting day, as well as how to kind of coordinate and triage your team when we are dealing with lens ordering as well as dispensing. And lastly, how do we actually follow up and what are our protocols for follow-up schedule, tracking patient concerns, and education and refitting as needed. So if you were to talk about our patient education section, there are three different parts that we're looking at. First is getting them information about the disease, the pathology itself, as well as making sure that they're on the same page. They understand genetics component, no eye rubbing, about cross-linking. There's a lot of overwhelming amount of information that we're providing at the consultation. So it's important to have different types of visual aids for your patient, whether it be verbal discussion that we do in the consult room. Secondly, having written information that you can send out to the patient so that they can kind of peruse through it at their own time, as well as providing information about support groups and resources that they can access if they have any questions or want to connect with people who have a similar pathology. Second part of the fitting, which is quite important, is your application and removal training. So in the application removal training does not begin when the patient is in the clinic for the training session. It actually starts prior. So in our clinic, we prefer to have a primer for the patient even before their visit. So that way they're a little bit more comfortable with how the visit would look like and what kind of a time commitment they're looking at, what is the process of applying and removing the lens. So normally we'll send them a video, we'll give them two homeworks actually. First is a video of applying and removing contact lenses in different ways so that they can familiarize themselves. Secondly, the homework is applying eye drops in your eye with your eyes open and prying open your eyelids. So that just makes the patient more comfortable first with opening their eyelids really widely. Secondly, when they get comfortable with something coming towards their eyes and not having a strong blink reflex. So it makes it easier for you to have the training done. Secondly, during the in-office training, we have our staff that works hands-on with the patients during the application removal training. A lot of times I've seen my patients will have their notes that they've written from the videos that we've sent to them in email, and they're already familiar with the parts on the tools that are going in with the scleral lens fitting. So sometimes just being familiar with all the tools actually helps and makes it a much more successful fitting session and application removal training session. Lastly, providing written instructions on the whole process, different techniques by which they can put the lens on. If they don't prefer using a DMV suction cup, using a tripod method, using a cup and putting a holder in it. So there's a lot of different ways we can get to the same result, but making sure the patient understands that there's no one correct technique, but there's a lot of different options for them to pursue the application removal. Lastly, we're looking at ongoing support, especially if patients have follow-up calls regarding the contact lens care, how to store their lenses, how, like, if the lens has some redness or irritation, your staff should be able to triage those calls and book appointments appropriately. And lastly, providing your patients with just handouts of products as well as alternatives for the lens care. When I first started in practice, I noticed that a lot of times the main concerns that the patients would have would be, hey, I'm at the pharmacy, but I'm not able to find the solution that you recommended. What other solutions can I use? So preemptively having those informations in a handout form to the patient over in an email and a digital form that they can always look through and they have those resources already provided to them always reduces those concerns, especially when those happen after hours and they are much more stressed. So in the clinic, we have a binder that we always give to the patients. Again, it could be a physical copy that we may give depending on the patient preference or a digital copy. So again, it will have the basics essentially built in: contact lens care and hygiene, the do's and don'ts of contact lenses. It will have information on different types of tools for insertion. So that way it makes their life easier. They know that there's a lot of wide variety of different ways they can apply the contact lenses. We're looking at techniques, written instructions on how to apply the lens, how to remove the lens, and then alternative solutions. Again, these are resources that are already present on Scleral Lens website, so it's important just to have those printouts and providing it to the patient. So that way they can feel more at ease and majority of their questions are answered. So this is one of my patients who had a very novel way of putting on the lens. So she got this eyelid opener from Amazon. It essentially like pulls the lids apart, and then she used her tripod method to put the lens on. So again, you will be always amazed at different techniques that the patients will be creative with and will find. And this worked wonderfully for her in terms of applying and removing the lens. She tried a lot of times with the DMV suction cup. It didn't really help, but when she was able to open her eyes really widely with the eyelid opener, it worked like a charm. So to see what goes better, like well with your patient, if they are not able to adapt to one technique, maybe try and pivot and try a second one. So these are some links for resources that you can access. It covers your scleral lens care, it covers handling guides, and also has commonly asked patient FAQs. So it's good for you to provide a resource that they can refer to. And if there's a question beyond what it's written out there, they can call and then get help from the clinic. So the next part is your staff onboarding. So when we're looking at training our staff, you want them to be adept at scleral lens terminology, what scleral lenses are, how they work, so that way they can provide a brief overview to your patients and get them accustomed to the process or how the process would look like. Having hands-on training with staff is always good. It's one of the things that all my team members have loved in terms of the application removal training. When they are able to do it on themselves, it's just much more easier to talk someone through the whole process. And lastly, building out your standard operating protocols in terms of booking appointments, having phone scripts, email templates, and FAQs. So you always want to focus on the patient journey from the point of inquiry to the point of finalization and just having those follow-up care. So once you have mapped out that journey and have your protocols for each thing, it makes it a much more repeatable process, and it makes the life of your staff much more like easier, just because they already know that they have a resource or a cheat sheet to revert to. So in terms of the lecture that I normally give my staff when I'm onboarding, it'll talk about scleral lenses, just a brief overview of it, how they work, indications for a lens, and how like they're beneficial to the patient. And then we go into the workshop. So in the workshop, we're actually doing topographies on each other. We'll check like what kind of maps we want in the exam chart. We'll look at application and removal. This is when the staff will apply the lenses on each other under supervision, and then we can see how comfortable they are with the contact lens. They understand the setup for the contact lens training much better in that regard. They know like what TMV tools that they need to put in during a training session, how the mirror should be set up, what preservative-free saline you need to use, and the cleaners. And lastly, they also like will talk to my patients about contact lens care as well as hygiene, the do's and the don'ts, so that the patient gets that redundant information first through me, then through my staff, so that information gets repeated quite frequently in the clinic. So building your resources and guides for your staff is key, not only for staff that you're training, but also for new staff that you may be onboarding. So having your standard operating protocols is important in just having those developmental guides that people can follow along and can have a much more structured approach to helping patients. Secondly, building out your phone scripts for patients who may be calling or referrals. So that way, when the staff gets a particular referral or an inquiry, they can answer the questions to the best of the knowledge. Looking at the email templates have helped us tremendously. A lot of my patients have been quite happy with the fact that we send them a lot of different emails throughout their scleral lens fitting journey. So one of the emails that goes out is a bit prior to consultation, where we'll have like their appointment details, the cost, and everything listed, along with we'll send them a digitized version of a scleral lens brochure so that they can read up about the lenses prior to their appointment. Second email that we send is normally after the consultation when they're going through the process. It is before your application removal training. So as I mentioned before, they'll get two different homeworks in that email. One would be watching the video of application removal. And secondly, you will get the homework of instilling eye drops. Normally, I'll give it for everyone except people who are very good at opening their lids. They've worn contact lenses in the past. I'll just have them watch the video. A lot of times you can easily tell when patients come in for the application removal training if they've watched the video or not, because my patients who have watched the video, they'll be very, very good. They'll already know what the setup looks like. They know which tool does what, and they'll be very quick in terms of learning. And then my patients some of them will be quite honest and tell me like, hey, I didn't get a chance to read it, but I can see how daunting the process can be. So let me go and watch the videos and we can do another session. Lastly, we're looking at your testing protocols. So when you're looking at testing protocols, you want to build a clinic flow that makes sense to your clinic, where like when you're waiting, that the staff is already doing testing. So when you have the patient come back in the chair, you have the maximum amount of data, and then you can finalize your fit or make adjustments as needed. In terms of outreach, we'll look at marketing your services and making it more well known or making people aware that you are offering specialty lens services. First is collaborating with your corneal specialist and optometrist in the community. See if there are opportunities for you to co-manage care where the patient is following you for specialty care, and then once their care has been completed, they go back to their local optometrist to continue with their routine exams and then see you periodically for their contact lens fittings. Secondly, talking to your existing staff, like your staff as well as your patient base, and seeing which patients might actually benefit from scleral lenses. There's a lot of time when we look back in our patient database, we can always think about patients who have like dry eyes or some sort of other pathology that may be good candidates. So bringing those conversations during the routine exam is, again, another starting point for you to talk about the services that you're offering. Looking at social media, online presence, building awareness in the community about lenses, how they work, common tips and tricks of how to use the lens and how the lens, essentially how to troubleshoot lenses, the cleaning solutions, and all of those things can be quite good resources for patients to look at. And lastly, updating your website. That's one of the key things that I would always pitch to my colleagues, that making sure you have a page allocated towards specialty contact lenses of what type of lenses you fit, how the lenses help. It should have the FAQs. It should define what the candidacy is for patients. And that actually helps not only in spreading awareness, but optimizing like your SEOs for Google as well. In terms of outreach and referrals, when you are reaching out to your cornea specialist and local optometrist, create a referral form that you can send to your colleagues while you're introducing your clinic and yourself to them. Secondly, educating your community, whether it be in clinic, whether it be locally by having just hosting educational sessions in your community. It can be quite powerful if you're talking to a patient. They may not have a condition, but they may know of someone who may have a condition or a high prescription, and they may benefit from it. So word of mouth always goes a long way as well. And lastly, internal referrals, checking in your database of patients which may actually benefit from specialty lenses, patients with dry eyes, refractive errors, keratoconus, post-LASIK ectasia. So there's a lot of different pathologies that we do see on a daily basis. The next thing is Google. If you have a Google business profile, optimizing your Google business profile and putting down your list of services, specifically putting down scleral lens services. Google now also has the opportunity to have a shop, so you can actually put your DME suction cups, you can put Addipac or anything that you may be housing for retail in there, just because it first helps with your awareness. If patients search you and they're able to see that you have scleral lens in the Google page, they know they can contact you. And a lot of times patients will find their provider through Google. So having those things built out is important. So in terms of building awareness, building out your website, as I said before, it's quite crucial. Having the right keywords so that when people are searching, you do come up in the Google search. SEO optimization is always important. Building out your blogs. Blogs are always good pieces of information that you can share out with your patients and the general community. Look, having a separate page for your services, specifically your scleral lens services, is important for them to know that there is a whole page dedicated to it and there is a specialty that you kind of focus on. And lastly, having FAQs on the page itself. So that way you can address, how do I know if I'm a candidate for the lens, or I have dry eyes, can I wear scleral lenses? So something that people can relate to. Social media is good in terms of sharing your cases, obviously, with patient consent, as well as talking about educational tips and tricks that patients may benefit from in terms of scleral lens use. And lastly, having just printed out brochures in your waiting room. A lot of times, my patients will love to take a brochure here and there. So having those set up in your waiting rooms, exam rooms, and clearly define who the candidates are, you'll sometimes be surprised that a patient will come in and they'll say, but I don't have an eye disease. Why do I need a scleral lens? But they may have really severe dry eyes. So always connecting the dots for them, it always helps them in the process.